As you know, right now we're having a lot of influenza cases nationally, and in Nebraska, we don't want to be known for this, but I think we have the highest rate of influenza right now compared to all the states. So it's a timely talk for us to do.
Yes, yeah, I'm glad we could have this topic. I think this is a great one to have. We've been getting a lot of questions, and I think this will help kind of go over some common questions that we get, go over kind of influenza in general, and just a great topic to have right now, especially while there's so much influenza going on.
Yeah.
So we have two kind of sets of data. We have some from the national level, and then some for Nebraska alone. And this is the first time where the CDC has actually given data during the flu season. Usually they wait till the flu season is over, and then they give data on the previous flu seasons. But this is the first time that they're giving data during the flu season. I think they wanted to show how aggressive flu is this year and how much kind of the high levels that we're having. And I think they're really doing a very good job kind of showing how things are going as they're going, as the flu season is happening. So this is the national data, and this came out pretty recently. This is showing the percentage of influenza A versus influenza B. And so you can see that it's mainly influenza A with just a little bit of B. And this is again, national data showing how widespread influenza is in the country. I kind of like watching this. They usually put up a little video that shows it spread across the country. And by the end of the flu season, it's widespread everywhere. Yeah. So the whole country is the same widespread color. So this is essentially just to show that it's widespread, and knowing that kind of changes things, because when it's widespread in the community, it changes kind of how to think about the patients and the testing that you do, and the approach to patient care.
And also Nebraska, state of Nebraska, and I think every state, they provide data weekly basis to make sure how the flu activity is going too. So we got the data from Nebraska Health Department. And currently in Nebraska as well, if you guys could see the gray line weekly, again, we're peaking right now, the flu season. So total positive influenza A and total positive influenza B. So A is the predominant strain, and it's at the peak right now compared to the past couple of years.
Yes, and it's very high. This is the gray area here.
And emergency department visit. So we're having a lot of emergency department visit early on the peak season. If you guys look at the darker blue and a little bit of the lighter blue lines, it started a little bit later in the influenza season last couple of years. But this year it started way earlier, and we're having a lot of visits, influenza-like illness visit in Nebraska in our emergency department. So that's important to know, because now then we could start thinking, how do we treat these patients? Do we need tests for all these patients? Or like an influenza season, if you suspect it, do we just give them Tamiflu as treatment? What we prefer is treat the patient. If if you don't have the right type of testing, if you suspect a high degree of suspicion, treat the patient with Tamiflu.
Yes, if they come in with influenza-like illness and there's a lot of flu in the community, then it's recommended to treat as influenza and not do a test, because if you test a patient with influenza-like illness and there's a lot of flu in the community and you have a negative test result, it's most likely a false negative.
And the problem is a lot of our emergency department are using the antibody test, and we'll talk about it a little bit later, but that has about 30% false negative tests. So, 30%, it's not very good. So you might, like right now in this season, if you do an antibody test, it might come back negative, but the patient has the symptoms and they truly do have influenza. So ideally, the test we should all be using is PCR, but a lot of places we don't have that technology yet in the emergency urgent care setting. So if you suspect, treat.
Yes, yeah. Yes, exactly. And this is the mortality surveillance. This is for Nebraska. These are 24 influenza-associated deaths have been reported for the season, and 2 pediatric deaths. Average age is 69.
So the type of signs and symptoms a patient that'll come with influenza, usually you have fevers, but the fevers are not always present, and especially in elderly patients, or if you're immunosuppressed, cancer patient, you might have the muscle ache, the headache, the lack of energy, dry cough, but you might not have fever. So we should kind of have, again, think about influenza season. If this is high right now, we should have a high degree of suspicion, even if a couple of those symptoms or signs are not there.
Yes. So if a patient comes in and they're an elderly patient, and we'll talk about high-risk groups and high-risk patients, if they're in those groups and they come in and they say they're feeling fatigued and tired, then really it'd be okay to treat and just say you suspect influenza and you're treating. Influenza, usually people talk about the second one here also, muscle aches or myalgias. If they have myalgias, or sometimes they just feel extremely fatigued and you don't really have an explanation for it, it'd be okay just to treat them and not necessarily to run any tests, just essentially treat them like they're influenza. And sometimes the patient or family might, wonder about the precautions and wearing a mask and everything like that, but it's okay just to say, we're trying to be on the safe side and treat as many people as we can.
If you can get the test, PCR test, that's great. If you can do the rapid test and it comes back positive, that's great. The problem is when the rapid test comes back negative, but the patient has the symptoms, then you should still have a high degree of suspicion and treat them. So that's where like 30% of the time, if the test doesn't work, especially the rapid test, we could miss a lot of patients.
So how flu spreads. So flu viruses spread mainly by tiny droplets made when people with the flu cough, sneeze, or talk. So there are some pictures of people sneezing and things coming. So that's how the flu spreads. So these droplets can land in the mouths or noses of other people who are nearby. They're propelled about 3 feet in the air. So just from a person talking, the respiratory droplets come out and they land on things. And when they land on things, you can also get it by touching a surface or object that the flu virus, if the flu virus is on it. So if a person with the flu walks around the hospital and breathes on things and touches things, then that's another way to get it. So droplet precautions are what's recommended. So that's a face mask. That's just a regular face mask when entering the room of a patient with a suspected or confirmed influenza. If a patient under droplet precautions requires movement or transport outside of the room, then you have the patient wear a mask and follow respiratory hygiene, cough etiquette, hand hygiene. So hand washing, again, we can't stress that enough.
Yes.
With all of our presentations, we talk about hand hygiene and the importance of washing your hands and everything.
Especially during the season, influenza, RSV, we're seeing a lot of coronavirus, lots of virus in the winter time. So I think the best way to prevent spreading is hand hygiene. So high-risk patients developing influenza-related complications. So complications, so children less than 5 years of age, especially less than 2 years of age, are high-risk patients. Adult greater than 65 years of age are high-risk patients. Pregnant females, and also pregnant females that just gave birth within the last 2 weeks. I would even go as far as the last 4 weeks. Their immune system is not very good, so if you're pregnant or postpartum, so they're really at high risk. Native American, Alaskan natives are at high risk. Morbid obesity, BMI over 40. And residents of a nursing home or chronic care facilities. So these group of patients are considered really high risk. But at the same time, we also have high risk conditions at the next slide as well, where if you have asthma, neurological, neurodevelopment condition, let's say you're paraplegic or you have other type of neurological conditions, chronic lung disease, so if you have COPD, bronchiectasis, heart disease like CHF, blood disorder, if you have endocrine disorder like our diabetic patient, our chronic kidney disease patients who are on dialysis, if you're cirrhotic with liver disease, metabolic disorders, weakened immune system. This is the weakened immune system incorporates a lot of patients that are on, for example, chemotherapy, cancer patients, patients that have like rheumatological disease, like lupus, and they're on all the immunologic medications, or if you have Crohn's disease, and they're on immunologic medication. So all those patients kind of fall into weakened immune system. And people younger than 19 years of age who are receiving long-term aspirin, and again, extreme obesity. So a lot of our patients will fall into all these categories when we think about it. So either they're at high risk group or they have high risk conditions.
Right, and these are important. So when you see patients and there's flu widespread in the community, so not only having a low threshold for patients that come in that you're considering flu, but also especially in these patients. So to highlight these patients as you'd want to treat if you suspect flu at all, but then especially in these patients,
yes.
And then also especially making sure that these patients get vaccinated. So we don't talk about too much about vaccinations in this presentation, but really this really highlights the type of patients that should be getting vaccinated. So if you're seeing patients that haven't been vaccinated, it's still not too late to vaccinate them.
Yes, not too late to vaccinate. And I always say in my clinic, if you're 6 months until you die, you should be getting vaccine every year.
Yes.
And that's kind of what I do. Like, I have 2 little kids, 2 and 4 years old. We all get vaccinated. My parents do. There's a lot of vaccine myths out there especially about influenza vaccine. You'll get the flu from the flu vaccine. We just did a couple of media presentations on that too, that the flu vaccine doesn't have any live particles to replicate. So you do not get flu from the flu vaccine.
Right, and the flu vaccine is actually, they've done studies that show that if you get it every year, even if it doesn't match up perfectly with this year's strain that's going around, it still helps in the long term. So because you're getting exposed to the vaccine, you can kind of get an immunity, and if it's very similar, or if there are strains in the future that are similar to the ones that you've gotten in the past, so even if they're not the exact same one, they still give you some protection where you may not get as sick, you may not die, or get as sick as you would have gotten. So when people say, oh, I still got sick, they may have gotten worse if they didn't have the vaccine.
So we have a question that says, how effective was the vaccine selection this year? So we won't know this year until end of the season to see how it worked and how effective it is. But what I always tell my patients, just like Dr. Horn was saying, is that, when you give the flu vaccine, even if it's not the strain, you're priming your body to think like, okay, you're giving them the vaccine, your body gets exposed, and now it starts making antibodies. So then when it truly, if you are then come exposed to the flu virus in real life, now your body's already primed to fight. So your bodies can say, when you're exposed to the actual virus, they're ready to start making more antibodies and be able to fight. The patients we see in the hospital, we have a lot of patients that we see in the hospital, in the ICU, with renal failure, pneumonia, MRSA infection. A lot of these patients have young people too. Most of them have not had the vaccine, so their body is not primed to fight when if they are exposed to the vaccine. So I think I would think of it that way. It's really important, even if it's not the same strain, to give flu vaccine yearly so our body can remember, start making antibodies, and ready to fight when we are truly exposed to the flu vaccine virus. When a lot of patients that do get the vaccine, when they do get the influenza infection, they end up recovering at home for 2 to 3 days. They might have some aches and chills, but they do okay. But the other patients who never got the vaccines are the one that gets into really bad complication, ICU admissions, MRSA infection, have bad outcomes.
Right, it's really the best thing we have to combat the flu. And here we have a bit more on influenza testing. So when influenza is widespread, the ILI, the influenza-like illness, can be assumed to be influenza without testing. And that's kind of what we were saying before. patients can be diagnosed clinically, do not require influenza testing for clinical management, including antiviral treatment. So you can give Tamiflu, you can give oseltamivir without having a definitive diagnosis, without having a confirmation testing. When prevalent in the community, a negative influenza test is likely a false negative. So when it's widespread, if you have a negative test, it's most likely a false negative. And that's kind of the converse of that would be if there's no influenza in the community, if it's summertime and you get a positive, it's most likely a false positive. So it just kind of a different way of looking at it.
And this happens with the rapid influenza antibody test. So if that's what we're using in our healthcare system, in ER, urgent care, clinics, or inpatient in the hospital setting, if you suspect, treat, because 30% it can be wrong. And that's a really high chance to take during this time. So it's really important to treat the patient with Tamiflu.
Right. And if you have the capability of doing PCR, so if you have, and some places like emergency rooms and things will do the rapid test. And if it's positive, they'll treat it as a positive. But if it's negative, then they'll go to the PCR testing and check with a PCR. But even if you don't have that, then if you still suspect it, I would recommend treating. But now use droplet precautions, hand hygiene, contact prophylaxis if they have symptoms.
So influenza testing, clinician should use PCR or molecular assay testing over rapid test, like we just talked about. Clinicians should not use rapid tests in patient except when more sensitive molecular assay are not available. So if you don't have PCR, then use rapid. But if it's negative, patient has symptoms, treat the patient, not the test. Follow-up testing with PCR or other molecular assay should be performed to confirm negative rapid test results. Treatment. So this is really important. So in the past, we had a lot of data on not giving Tamiflu if the symptoms happen for more than 48 hours. So we'll touch that. Start antiviral treatment as soon as possible for adults, children with documented suspected influenza, irrespective of influenza vaccine history, who meet the following criteria: persons of any age who are hospitalized with influenza, regardless of illness duration, outpatient of any age with severe or progressive illness or high-risk complication, like that group of people we talked about. This season, it's okay to give influenza Tamiflu even in the outpatient setting or inpatient setting, even if it's been more than 48 hours. Tamiflu stops the viral replication. So it stops the virus from replicating. In certain patients, the virus can replicate up to 2 to 3 weeks, especially in the immunocompromised patients. So it's really key to give Tamiflu as soon as you can, irrespective of how long they have had the symptoms.
Right, and this is a question that we get frequently. So if the patient is hospitalized with influenza, so sometimes we'll look in a chart and it will say the patient has influenza, but it's been longer than 48 hours, and they decide not to treat. But that even happens in patients sometimes that are in the ICU. So if patients are hospitalized or in the ICU, really we don't have that much we can fight flu with. So we try to use everything we can. So if the patient is hospitalized, if all we have is oseltamivir and symptom support, then recommend giving oseltamivir. It won't hurt, and it might help. So with patients that are hospitalized, we always treat.
Yeah.
And then the other question is how long to treat in the hospital while the patient's hospitalized. Well, if the patient's still having respiratory symptoms and fevers and they're ongoing, and these are high-risk group patients that are very sick, you can consider treating longer than you normally would.
So if you would treat somebody for 5 days regularly, if somebody is really sick in the hospital setting, you could even extend it up to 10 days. And currently, the new influenza guidelines is available too, that just came out early this year. So they recommend the same things as well. So it's brand new guidelines. They recommend, okay to give Tamiflu after 48 hours. You could extend the duration for really sick patients that are immunosuppressed, really ill in the hospital.
Right, and those studies looking at 48 hours, I think that was originally for outpatients that were healthy, that were doing
Yeah.
okay, and it will cut down symptoms a little bit, but it didn't really help too much if it's been longer than 48 hours. But people that are extremely sick, it doesn't apply to those patients.
Antiviral treatment is recommended as early as possible for any patients with confirmed or suspected influenza, is hospitalized, has severe, complicated, progressive illness, is at high risk for influenza complications.
So this is another way of saying the previous slide. This is just a different way, and this is these are CDC recommendations. Yes. So another question we get is about secondary infections. We get questions related to their influenza is positive. How do I know that they don't have a secondary infection? And this is a common stewardship question. This is a common question that we get for patients where you want to do everything you can for the patient and you're not sure if they have a secondary bacterial infection. Should we just give Tamiflu or should we add antibiotics as well? And so if you're going to add antibiotics, this is a chart of community-acquired pneumonia and the common bacteria that we see. So it's important to look at, these are patients that got pneumonia as an outpatient, and then this is where you treat them as an outpatient or as an inpatient, or if they go to the ICU. So sometimes if someone is sicker, then they might have different bugs making them more sick, requiring them to go to the ICU. So the important thing about this one, you don't have to memorize the whole thing. It's just essentially to look at it and see that strep pneumo is the first one on each of these. Strep pneumo, strep pneumo, strep pneumo. So whatever you give, if you want to give something for a pneumonia, it's really important to treat strep pneumo whether they have influenza or not.
Yeah, but the tricky part is this is usually what happens most of the community-acquired pneumonia. Like Dr. Horn said, always focus on strep pneumo as one of the big pathogens. But if you have influenza and a pneumonia, bacterial pneumonia, you also have to think about Staph aureus. So it changes in the inpatient or outpatient. You have to think about Staph aureus. So I think next slide.
Yes. So Staph aureus moves up, and you want to make sure you cover that as well in patients with influenza.
So if you have influenza, if you have a secondary bacterial pneumonia, the majority of time, the bacteria you have to focus on is Staph aureus. It could be methicillin susceptible Staph aureus, or it could be methicillin resistant, so MSSA or MRSA. And the second most common is strep pneumo, and third is Haemophilus. So let's say we have a patient coming from the community and they have influenza and community-acquired pneumonia, usually we will do for community-acquired pneumonia ceftriaxone and azithromycin. But in this case, you have to think about we have to cover for Staph aureus. So you will change that to ceftriaxone and doxy, because then doxy is going to cover the Staph aureus. Ceftriaxone will cover the strep pneumo and Haemophilus influenza. So you have to think about, on top of your regular coverage, adding coverage for Staph aureus. If it's a non-complicated patient, you could think about Bactrim and doxy, but if they're a complicated patient, please add vancomycin.
Right, and classically, when you think about secondary bacterial infections on top of a viral infection, as far as, and they put this on medicine boards as well, they'll have a question where the patient has influenza, you're treating them, they get better, they start to improve maybe a couple days, and then all of a sudden they do much worse. And they say, I was getting better from influenza, then now I'm all of a sudden sick again, I'm having fevers again, I have tachypnea, so they're short of breath all of a sudden. And for those, that's the classic example where you have to say they have a secondary infection, a secondary bacterial infection on top of influenza. And they can also get secondary infections, bacterial infections from coronavirus, RSV, other types of viruses as well.
The biggest thing that we see with influenza, majority of the time, I can't emphasize enough that if you're worried about a bacterial infection, Staph aureus, MRSA and MSSA causes a lot of mortality and morbidity, and causes a lot of bad pneumonia, bacteremia. We're seeing that a lot right now. So I think it's so important for us, if you have an influenza patient, to cover for MRSA and MSSA until you guys get more culture and clarification. Empirically, if you're worried about a bacterial infection, think about making sure that we cover for MRSA and MSSA.
Yes, and the patients, especially when they have large outbreaks. When the patients that die from influenza, many of them had a secondary bacterial infection. So the influenza knocks down their immune system, and then they get a bacterial infection on top of it, and their body can't deal with it. So, and last year, I think Nebraska put out an advisory that
Yes.
said just that.
So Nebraska Health Department last year sent out an advisory, and I think they also did it earlier this year as well, to make sure that we all consider bacterial infection, and if there is a bacterial infection, to make sure that we're covering for MRSA and MSSA. So those, if you want an oral agent, consider Doxyobactrim. If you want an IV agent, consider vancomycin or other agents that will cover MRSA, MSSA. But I cannot emphasize enough, because that's what we're seeing right now. So make sure we all have that in our back of our mind.
So we don't need to focus on this, but we just wanted to touch base on this. This is viral pneumonias, and the X-ray findings and how it's kind of patchy, infiltrates, kind of diffuse, and then compare that with a consolidation here. So this is a consolidation with a bacterial pneumonia. It looks a bit differently, but I wouldn't say to base everything off of this. Yes. I would say this is just essentially an example.
What antibiotics should I use if I suspect a secondary bacterial infection associated with influenza? Just like we talked about, we have to cover these two organisms. So to cover these two organisms, I think our next slide.
Yes, so essentially look at your hospital antibiogram and see what's recommended for your hospital, for your area, and take the patient into consideration as far as their kidney function, which we'll talk about next, versus their allergies and
something to keep in mind. Clindamycin doesn't cover MRSA really well, or MSSA. There's about 50% resistance, or you could have inducible resistance. So a drug that will drugs that can be used that will cover Staph aureus, your go-to should be Doxyobactrim oral agents or linezolid. They all have good susceptibility. And then otherwise the IV agents like vancomycin.
Yes, that's a very good point. Yeah. So sometimes patients are on Clinda, and we'll talk to the provider and they'll say, well, MRSA is covered.
Yeah.
But not really.
Not really, because...
So if it's your family member, if it's you, and if it's only 50%, 60%, that the likelihood that you're covering it, I would consider it not being covered.
Unless you know the susceptibility and you could confidently use it, we should not be using it empirically without knowing the susceptibility pattern. Yeah.
So what antibiotics should I use if I want to avoid vancomycin plus piptazo due to AKI? So in these patients that have influenza, a high majority of them are going to be 65 years and older. And so not all of them have very good kidney function. And if you want to avoid kind of harming their kidneys, this is a common question that we get. So ceftriaxone plus doxycycline is a common regimen. The doxycycline will cover MRSA, and the ceftriaxone is there to cover strep pneumo as the beta-lactam. Anytime we can use a beta-lactam, that's what we would prefer. And then we also have ceftaroline. So ceftaroline, think of it as ceftriaxone plus MRSA coverage. So it covers strep and staph very well. It's the only cephalosporin that covers MRSA. So if you have ceftaroline, that would be another option. And then linezolid is another option. If this can be given PO. So not all facilities have ceftaroline on formulary. And if a patient is unable to take ceftriaxone and doxycycline, or if linezolid would be another option.
Yeah, linezolid is good for strep pneumo and MRSA. Just remember, it doesn't have any gram-negative, so you have to add some gram-negative coverage to the linezolid if you're worried about gram-negative as well.
Yeah. So these are some of the options. Bactrim would also be an option, but we didn't list it here because of the AKI, and that sometimes you try to avoid Bactrim. So what dose of ceftriaxone do you recommend?
Usually we give 2 grams, but if a patient is really sick, in the ICU on pressors, they're crashing, we go up on the dose to 2 grams Q12. It's the meningitis dose, but we increase the dose for really sick patients. Or if they're BMI, body mass index, they're morbidly obese, it's okay to bump up the beta-lactam dose.
And there are some studies showing that if a patient comes in and they're very sick, they get so many fluids, 30 milligrams per kilogram in the first couple hours, within the first 3 hours. So the volume and distribution goes way up, and giving more of the ceftriaxone is common especially for ID doctors in this situation. Then there are some studies they kind of look and they give ceftriaxone 2 grams, and then about 6 hours later or so they check the blood again. They don't see any ceftriaxone in there, and it's kind of one of these things where and this is meningitis dosing, so it's giving high doses, trying to give beta-lactam to these sick patients, and trying to just essentially being very aggressive when the patient comes in and they're very sick.
So influenza treatment. So we have multiple antivirals in the market. Tamiflu, oseltamivir is what we all use commonly, oral agent. You also have the inhaled agent, but you can't use it on patients with any asthma or COPD, or if they're intubated, it could cause bronchospasms. Pneumonia is an IV only, so let's say you have a patient who has gastric dysmotility, ileus in the ICU, they have influenza. This is a really nice go-to drug because it's an IV drug, and it still will target both influenza A and B. So if you could take orally, you want to give Tamiflu. If you cannot take oral, you're intubated, sedated, ileus, no gut motility, give Pneumonia. It's IV dosing, and it works effectively. The exciting thing is we have a new antiviral influenza medication, baloxavir, just got approved. It's also oral agent, but it's just 1 dose. I have not used it yet. I don't think.
No, I haven't used it either.
Yeah. And I don't know what the cost is yet either. If anybody has used it, let us know. But the nice thing about it is it's not inferior to Tamiflu, works effectively just as Tamiflu. And a really good thing is it's only 1 dose. I know a lot of my patients have issues when they take Tamiflu, nausea, vomiting, a lot of like GI type symptoms, and you have to take it for 5 days. But this is 1 day, so I'm assuming it'll start being used more. Hopefully it's cost effective.
So preventing the flu. So the single best way to prevent seasonal flu is to get vaccinated each year. So we really can't stress that enough. Good health habits, covering your cough, washing your hands, can also stop the spread of germs and prevent respiratory illness. There are also flu antiviral drugs that can be used to treat and prevent flu. So we'll talk more about preventing flu with Tamiflu. Preventing the flu, and this is from the CDC, avoid close contact, stay home when you're sick, cover your mouth and nose, clean your hands, avoid touching your eyes, and practice other good health habits. So these are the things, especially with children and things like that. Yeah.
So chemoprophylaxis. So a lot of people ask us about, we get this question a lot. Mm-hmm. So if you have a child at home who has influenza, is it worth giving the grandma at home Tamiflu to prevent getting influenza? And definitely it is. So it inhibits and approximately 70 to 90% effective in preventing influenza against suspected influenza viruses, and a useful adjunct with influenza vaccine. So we have data. It says it helps 70 to 90%. Recommended duration for prophylaxis is 10 days. And for control of outbreaks in institution setting, like hospitals, if you have an outbreak, you could give prophylaxis for about 2 weeks. Antiviral chemoprophylaxis is recommended for all residents, including those who are received influenza vaccine. So what I usually say is, let's say I have a 2-year-old patient with influenza, and there's a pregnant mom at home, and there's another 4-year-old at home, and a 65-year-old grandma at home. Ideally, they should all get chemoprophylaxis because I just listed all high-risk group, the pregnant mom, the 2-year-old, the 65-year-old grandma. But it's also okay to give the dad chemoprophylaxis also, because then, you prevent the whole family from not getting influenza. I just did that for another patient the other day. Their 2-year-old daughter had influenza, so I prescribed prophylaxis for mom, dad, and their 4-year-old son. So, and so far, none of them have gotten it, so it is effective. cost prohibitive sometimes, but it's very effective. Would your prophylaxis be daily or BID dosing? There's been some, in CDC, if you look at, there's BID and daily, but I think daily dosing is fine. But usually for prophylaxis, you're supposed to do it for 10 days.
Oh, and so this is something that you just discussed, exposed due to a family member. And this is another question we get. They'll say, the family members have not had the flu shot this year. Is it okay if they get the flu shot and get Tamiflu at the same time? Yes, that's good. Yeah. And in ID, sometimes they talk about missed opportunities. And so when you see a patient and when you're thinking about contraindications to flu shots, there are really almost no contraindications to flu shots. You want to give the flu shot to as many patients as you can, really.
Yeah. Unless you had Guillain-Barré syndrome, like really bad outcome from a long time ago, you know, even egg allergy is not a contraindication for flu shot anymore.
Right, and patients that come in and they have like a mild cold or they're not feeling too well, that's still okay to give them the flu shot.
Yes.
Because you don't want to have a missed opportunity, because sometimes the patient will say, well, how about I come next week when I'm feeling better? And then the studies kind of show that they don't come back. Either they don't remember, or they just so that's why they call it a missed opportunity.
Thank you. Somebody just shared the cost of the new antiviral for influenza, generic Tamiflu, and the cost of it. Thanks for sharing it with everybody.
So, and this is another something that comes up, and there was another question that we got, and this is really for the 2018-19 influenza season. Should we be giving children 6 months to 8 years 2 shots? Yeah.
So it's common practice in pediatrics is that if you're between the age of 6 to 12 months of age, you usually get, if you have never received vaccination for influenza before, you get 2 doses. So even if up to 8 years of age, if the patient has never received influenza vaccine up to that age, then they should get the 2 doses. But if you have a 3-year-old and at 2 years of age, they got influenza vaccine at 3, you just give them 1 shot.
And really, essentially, everybody else just gets 1 vaccine.
1 vaccine.
One vaccine a year.
Yeah.
We're not talking too much about vaccines, but the other thing is that people say, what about HIV patients with lowered immune systems? So because it's essentially a dead vaccine, so it's not a live vaccine, they can't get the flu from it. So it's still okay to give it to them if you think that they'll be able to respond. It won't hurt them, and it might help them. It's kind of the way to think of it.
If you have, for example, HIV, if you have an HIV patient or immunocompromised patient and you're using nasal influenza vaccine, it was off the market last year, and I think it's in the market this year. You don't want to give that because that's live virus. But if you're just giving a shot, influenza shot, you could give it to anybody because it's dead virus. There's no replication, no contraindication.
Mm-hmm.
What are your thoughts on the new approval of influenza vaccine dose for 6-month-old?
0.5 for 6 months instead of the 0.25. So I don't do peds, so I'm not really sure about that question.
I'm not particularly sure about that question, but
in general, giving higher doses is better, and that's what's been shown with the standard dose versus the high dose. So if a patient is 65 years or older, the CDC says you can give any shot. The CDC doesn't really take sides. But the evidence is really showing that the higher doses for patients that are 65 and older are superior than to the standard dose.
So I cannot, I don't know the studies, but going from that assumption, if you give a higher dose, we could get higher titers for our kids to protect them better.
Right, I would assume it's better.
Yeah. We could look into that and see and send you guys some information as a follow-up. Right,
and these studies, some of them are based on, they're called immunogenicity studies. Mm-hmm. So they look at how well the patient responds after getting it. But and then they correlate that and say if the patient's immune system responded better, that it's probably better, and that's usually what it shows. So I would assume that that's better, but I don't know specifically about those studies. Yeah.
When to take out of isolation precaution? Oh, this is a great question. So we get asked this a lot. So if a patient is in the hospital, Droplet Precautions for 7 days after illness onset, or 24 hours after the resolution of fever and respiratory symptoms. So when I say, oh, not just a fever, the respiratory symptoms, meaning they cannot be coughing, they cannot be having runny nose, because if that's still happening, you still have virus in there, it's replicating, shedding, and you could give it to somebody else. So ideally, droplet precaution for 7 days or the 24 hours after onset of fevers and symptoms resolution.
Yes, and these are CDC recommendations, so
Yes.
all hospital needs to come up with their own recommendations, and so I'd say follow your hospital follow your hospital recommendations.
Yes, agreed.
But because sometimes the patients, if you take them out 24 hours after the resolution of fever and then they have another fever, then you say, uh-oh. You say, we should have kept them in isolation precautions longer, and then you get a lot of people that get worried and they say, well, I was in that room and now they're having fevers. So that each hospital kind of has to make their own decisions, and this is what the CDC goes by.
Yeah, and then when they say resolution of fever, sometimes your fevers might go away, or some patients might never have had fever. But if you're still having cough and runny nose, you could spread that to other patients in the hospital.
So it's probably better to keep them in isolation. Well, if you're going to pick, it's probably to keep them in longer rather than take them out earlier. It really saves infection control and everybody kind of a big headache.
Another good question, thought to think about is if they're on Tylenol or ibuprofen, their fevers might be masked. So then you might actually think they don't have a fever, but in real life they might be having a fever, but we're giving antipyretic medication. So in that case, look at the symptoms. See if they're having runny nose, cough. They still continue to have those symptoms, keep them in isolation. This is to protect your employees and the other patients in the hospital.
Right. So, and this is another question that we received, black elderberry syrup. So there's kind of a question is, should this be used, or what are our thoughts about black elderberry syrup? So I really try to stay with what's in the mainstream and with what's recommended by the CDC. And so this isn't widely recommended yet. I think
this is not part of the CDC. So as ID doctors, we don't recommend it. For us, when we look at evidence-based, going with guidelines and new influenza guidelines, what we recommend is antiviral medication like Tamiflu, influenza vaccine, and things that we talked about. So I cannot comment on this because I'm not an expert in this area, and I do not recommend this to my patients.
Right, I don't recommend it. I completely agree. We go with strong evidence and
what we are taught.
Yeah. And that concludes our presentation about influenza. If you have any additional questions, feel free to type them now or email us any questions that you have. If you'd like to take yourself off mute and ask any questions that you have there in the room, we'd be happy to answer them.
Do we know if black elderberry syrup interacts with the antivirals? Good question. I'm not sure. I'm not sure about that.
I'm not sure if it has any interactions or not.
Any thoughts on recombinant flu vaccine, Flublok, quadrivalent versus egg-grown high dose? I have been reading a lot about Flublok recently, the quadrivalent. It's from some of the studies I'm looking at, it has a lot of adjuvant built into it. So I just recently read a study where it said that I don't promote any vaccines, I don't work for any companies, but what I did read is that it was able to produce more antibodies, especially when they did the study in elderly patients. So I thought that was interesting, the quadrivalent, being able to produce more antibodies. I'm always in favor of producing more antibodies and more protection for the patients.
Yeah, and I think part of it is really egg allergy and which influenza vaccines people can take and everything. But and the CDC really doesn't take sides. They recommend any shot, any flu vaccine is.
So our institution had an outbreak around Christmas. We have had a visitor restriction since then. Recently, we have not seen much flu. Would you recommend removing the visitor restriction. I think it's important to evaluate each, like your institution, your numbers.
Yeah.
But if influenza is so high in the community, so if you do have flu restrictions, it might be okay to still continue that for a while. It's hard to say for me from here, not knowing the activity around your area. But if you're in Nebraska, it's probably okay to still keep it because we are one of the highest right now.
Right. I think it sounds like those visitor restrictions really made a difference.
Yeah.
So, but it's hard to comment on specific places. Yeah. Because it's. Oh.
So based off the new recommendation, we would be okay to offer egg allergic employees the regular influenza instead of flu block going forward. Is there any reason to ask the egg allergic questions on the influenza question part? So it's okay to give the vaccine, but what they did recommend is if they had severe egg allergy, when you're giving flu vaccine, you should monitor them for 15 to 30 minutes.
And a severe egg allergy.
Yeah.
So it's not just, I think it's not just hives or a little rash with egg allergy, it's actually extreme.
So I would just go off the Packard insertion and the CDC recommendation, but if there is a concern for that, you should have a place to monitor the patients to give the vaccine. What is the consensus on the latest version of Flu Mist? So last year they took it off the market. It's back on this year market again. I'm not really sure how effective, so we have to wait and see what the data is.
Right. I haven't been recommending it.
Yeah.
Right. Yep.
And usually the Flu Mist is for patients 2 years of age to 49 with no other comorbidities. So I am not sure how good this year's. We have to wait and see for next year's data.
And the next question, we struggle getting all of our employees vaccinated. Some refuse and must wear masks when outbreaks are high. What is the magic to get people vaccinated?
That's a really good question. Some of the institutions we work for, we have this in the past, and as an institution, we decided at certain places that it is best for our patients and our employees to mandate vaccinations. And if there's a reason that they're refusing, they need to have a doctor's note. Certain places, so our employee current vaccination rate is about 99%.
99%. And I personally think that's wonderful.
Yes.
I think that, if there are employees that say, I never get sick or I don't get it, I kind of think of it myself as, I don't get sick really with flu, but if I were to pass it on to one of my patients and they were to get sick or die from it, I would feel terrible.
Yeah.
And that's kind of what that's how I think about it myself. And that's how I try to convince people to get the flu shot. But
I know there's so much myth about the flu shot,
right,
and there's so much, they Google and they find a lot of information, but certain institution where we work, it's mandatory, and you have to produce a doctor's note, medical note, why you cannot receive it if there's a reason. And then they have to wear a mask during the influenza season in the hospital setting. So that's kind of what the policy that I am used to. And we don't like to dictate, but I'm glad that we're able to do it certain places because it really has helped our patients and other employees.
Right. And we've had questions before about patients that have received kind of alternative medicine and asking not to get vaccinated, or saying that they don't want to get vaccinated because they've received an alternative medication. And really, I stand by the
vaccine.
The vaccine, yes, yeah.
Any other questions? We have had lots of great questions today. Hope we were able to answer them okay. I know there are some questions we'll send you guys some follow-up material on.
Yes, thank you everybody for joining us. I think this was really excellent.
Yeah. Thank you.
Oh, thank you. Yes.
Thank you.
So if anyone has any questions about this presentations, please email us if you have any recommendations for future webinars that you'd like us to discuss, or anything we'd like us to address at all,
And
please let us know.
next month, our webinar will be on the daily flow for antibiotic stewardship pharmacists and how we do the daily workflow. So our pharmacy faculty will be doing that next
Yes, we're having 2 excellent pharmacists. We're having Ashley Mauser from Kentucky, from Hardin Memorial, and then we're also having Sumaya, which is our pharmacist that we work with daily, to kind of review and go over workflow and it's antimicrobial stewardship from the pharmacy perspective, which I think is going to be a fantastic presentation.
Yeah. Thank you.
All right.
Have a great day.
Thank you again, everybody.
Thank you.
Thank you.